Hello everyone, and welcome to the Understanding Interstitial Cystitis Bladder Pain Syndrome webinar. We're glad you're here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as by donations and memberships to CIRPD. As I mentioned, my name is Tanya, and I'll be moderating the webinar and handling the Q&A session. And our presenter today is Dr. Curtis Nicol. Dr. Nicol is a professor at the Department of Urology at Queen's University, and he's also the Canada Research Chair in Urologic Pain and Inflammation. And he is also the Vice President of the Canadian Urological Association. Dr. Nicol's research covers inflammatory, benign, prostate, and pain diseases of the urinary tract. He has over 500 publications, is on the editorial board for 8 urology journals, presented in 45 countries and funded by US, NIH, and Canadian CIHR, and was awarded the CIHR Tier 1 Canada Research Chair. We're very excited to have you with us today, Dr. Nicol, and I will hand it over to you for the presentation.
Well, thanks a lot, Tanya. As Tanya said, my name is Curtis Nicol. It's a real pleasure to be here and present on a topic that I've become very interested in over the years in the last decade or so. My background was microbiology, and I became very interested 30 years ago in chronic prostatitis, being reasonably sure that I would be able to find the smoking gun organism that was causing prostatitis and pain in males. I have a research prostatitis clinic, and I've been running that now for 25 years. But we were also seeing men with interstitial cystitis with chronic pelvic pain and making that diagnosis. And I noticed I was getting a lot of referrals of women with a diagnosis of interstitial cystitis to our male prostatitis clinic. So that was one of the main reasons I got interested in interstitial cystitis, bladder pain syndrome in women. And it was about 15 years ago we opened up our interstitial cystitis clinic. We opened it up to all of Canada, and within 14 days we had 500 new unique referrals. So there was a huge unmet need. And then I became interested in the science behind it and the associations with inflammation, infection, pain, and the psychological and other pain associations with this. So I was going to actually present something today about understanding the patient with interstitial cystitis, bladder pain syndrome, but I thought what I would do instead, because I found people liked it a little bit better, particularly this kind of diffuse or divergent audience, which includes physicians, healthcare personnel, and patients. I thought what I would do in the next half hour is tell you what I've learned from 15 years of taking care of patients with chronic pelvic pain. Particularly in this particular instance, we're going to be talking about females with urologic chronic pelvic pain and where we're going with this. And then I'm going to have the pleasure of taking all your questions. So this is going to be more of what I learned, but I think it's going to be valuable to physicians and healthcare personnel that deal with this. It's also going to be illuminating and enlightening for patients who have this condition on trying to figure out what we in the research career are thinking right now. To start with, the first tip I give physicians who are managing this is at this point in time in 2017, we cannot cure this condition. We can't cure it because we don't really understand what causes it. So a number of years ago in 2012, we put together a comprehensive review of all the literature, of all the treatments that have ever been used in interstitial cystitis. And we came to the unfortunate conclusion that not one treatment managed all patients with interstitial cystitis, but the corollary was some of the treatments were very effective for some of the patients. Now that was 2012, and in the intervening 4 years there's been a few more treatment trials, and none of them have changed our conclusion that there is not a one silver bullet that will treat this particular condition, and that this particular condition has to be dealt with in a much different way. Now, what I'm assuming here is that the physicians, the healthcare personnel, and the patients all understand the basics of this condition. We all come to this knowing that it is a chronic pain condition of the bladder that may or may not be associated with inflammation and or previous infection that results in pain perceived to be in the bladder with urinary urgency and frequency. By the time I'm done, and you'll learn what I've learned, that it's really much more than that. So the first thing I do is tell physicians, because this is what I've learned, is to set very realistic goals with the patients who I see for the first time. And it's not my goals as a physician. It's patient-related outcomes that become the goals, and these are individualized for each specific patient. Now, the patients, of course, who come to see me would like me to wipe out their pain, to stop this urinary frequency and urgency. And I might not be able to do that, but what I will do is help control the pain and see if I can reduce the urinary frequency and urgency. But our outcomes are primarily going to be patient-related outcomes. Can we increase our activities mentally and physically? Can we sleep better? Will our general well-being be better? Can we go back to work or work more effectively? And will our social interactions be improved, including sexual interactions that may be impacted by this chronic pelvic and bladder pain? These are the outcomes that I work with my patients, with my interstitial cystitis nurse. One of the things I've learned is that we must not only listen to the patient, we must examine the patient. And this is particularly true for chronic pelvic pain. This examination, which is sometimes missed by many physicians, including urologists, is a very comprehensive evaluation of the pelvic floor, the vagina, the vulva, looking for vulvodynia or pain in the vulva and vagina. It's looking for pelvic floor dysfunctional pain. It's examining and evaluating the tone of the pelvic floor muscles. It's looking for myofascial pain or trigger points that bring about the pain. And finally, in that examination, we examine the bladder itself with bimanual palpation, with one hand on the abdomen suprapubic area and one in the vagina, see how much pain there is in the bladder. This is very important, and it's something that's missed more times than it's not. And it helps us decide on the patient's what we call clinical phenotype, which I'll explain later, and how we're going to direct therapy. The other thing is cystoscopy. It's interesting, the cystoscopy, which is actually having a look at the bladder, is not a mandatory evaluation for patients with pain perceived to be in the bladder. What better way to examine an organ where we think there's pain, to look for inflammation and or other abnormalities than doing a simple cystoscopy under local anesthetic? And yes, patients have urethral and bladder sensitivity, but this can be taken care of in the way that I describe with patients. What we're looking for, one of the things we're looking for is these things that I show here, these Hunner's lesions, which do not have to be seen under general anesthetic, do not have to be examined with a hydrostatic bladder dilation, which in some cases can be risky to your health and also risky to the bladder if this is done on multiple times. So Hunner's lesions occur in 10 to 20% of patients, and these can be treated effectively with very minor surgical procedure. And I've been amazed at taking patients with pain scores around 9 to 10, disabling pain that doesn't allow them to work or have sexual relations, to a patient who is almost normal with a 5-minute operation. But we have to find these first. Now, I'll just go back. Tip number 4 is looking beyond. So the patients come to us as physicians or with urinary urgency and frequency, pain in the bladder that is worse as the bladder feels, better when the bladder is emptied. And what we do is we tend to focus, particularly as urologists, we focus on the bladder. Gynecologists tend to focus on the vagina, the uterus, and the ovaries and forget the bladder in chronic pelvic pain. So what's interesting is you see the figure on the left. This is a compilation of hundreds of patients that we've seen where they've marked where their pain is, and only 20% represent that patient with pain in the pelvis only. 80% of patients have pain that can be quite severe and disabling, and maybe even a primary pain generator beyond the pelvis. And that's represented by the figure on the right, a compilation of multiple patients, even though each patient in our center will complete one of these pain diagrams to let us know where the pain is. Now, let me see. Isn't it awful when, there we go. Now, as long as we're looking at pain beyond the pelvis, where is that pain? Well, it's associated with diagnosis of other chronic enigmatic pain syndromes. So if we take 100% of women, like in this of 207 of my patients, with interstitial cystitis bladder pain syndrome, and look at control patients, age-matched, who do not have any bladder pain, we can see that there is a very high risk of having irritable bowel syndrome, as high as almost 40%. But when we actually look for irritable bowel syndromes, it's much higher than that. It's even getting closer to 60%, compared to the normal population of interstitial cystitis, or of irritable bowel syndrome, of about 5 to 6%. Fibromyalgia, 1 in 5 patients with interstitial cystitis has this condition, compared to the background of about 2% in the general population. Chronic fatigue syndrome, 1 in 10 versus a very low rate in our control population. Vulvodynia, close to 1 in 12 patients complain of vulvodynia, where it's very rare in the control population. Migraine headaches, tension headaches, temporomandibular joint disturbances and disorders, low back pain, are all much higher in the IC patient than in the control population. So we can predict that if we use a treatment that's directed only against the bladder, we're going to end up with an ineffective treatment because the patients have pain elsewhere, and they might be the primary pain drivers. Now the bottom psychiatric condition, a third of the patients have a psychiatric condition. That's pretty, what we say, misleading, because it's not a psychiatric condition that causes this. It's a psychiatric condition that is driven by the pain and other symptoms. And I'll show you what I mean in a couple minutes. And that's been a real eye-opener, because one of the caveats when I learned urology was that patients with interstitial cystitis, once you found no pathology, the patients perhaps had some sort of psychiatric crazy type of approach to mild pain. That is not so, and I'll show you why. Now, we developed a phenotyping system for chronic prostatitis in men called U-Point. U-Point stands for the major phenotypic differences in these particular patients or domains that we thought were important in describing a patient's experience. Now, it works very well in males, less so in females with interstitial cystitis bladder pain syndrome, because by definition, to have this diagnosis, every patient must have urinary symptoms and have organ specificity. In other words, pain in an organ, and in this case it's the bladder. But it also helps us look at psychosocial attributes, infection either at the time or previous infection, neurologic or systemic symptoms, and that would include their associated conditions, and tenderness, which really refers to pain or tenderness in the pelvic floor. This helps define the clinical picture, but you also have to take into effect the previous slide of the associated conditions. So once we've made the diagnosis, we've decided on the individual patient phenotype or clinical picture that patient is presenting to. How are we going to manage that? Well, the most important management principles that we have is education, diet, and exercise. Education, now for one time, is educating physicians that they need to understand this condition, but it's also to educate patients. Educate patients to what they have, the fact that we don't really know what causes it, the absolute fact that we may not be able to cure them, but that we may be able to get them better, the fact that they're not crazy, that they have a condition that we can quantify, that we can diagnose, that we can evaluate, and that we can treat. That's extremely important. It's the first step, I find, in getting the patients into a better quality of life and management place. Diet has turned out to be one of the most successful treatments in our clinic. And this was driven by patients' experience and patients' reports, so that now we have an idea of the type of diet that causes more pain, more urinary symptoms, and more flares. And that is based on multiple thousands of patients inputting. Now, some of them we know quite well. It's a cup of coffee. Now, the cup of coffee will create sort of a diuresis, so you'll pee a little bit more for the next hour. But we now know that a single cup of coffee on Monday will affect an IC patient's urinary and pain symptoms until Friday. 5 days of pain and urinary symptoms from a simple cup of coffee if the patient is sensitized to coffee. And everybody is different. I have IC patients that coffee doesn't make any difference. We can stop it for a month and nothing happens. We can restart it and nothing increases in terms of pain and urinary symptoms. Nuts, chocolate, acidic food drinks. For some patients, it's wheat. For other patients, it's milk products. But every patient has to go on an elimination diet, eliminate all the possible target foods, see how they do for a couple of weeks on this very bland diet, and if they're better, start adding one food at a time to see for them what they have to avoid for absolutely the rest of their life. And for many patients, education and diet is all we need, diet modification. Now, exercise has turned out to be extremely important in our clinic. And when I mean exercise and exercises. Exercise, we have a very nice YMCA program for chronic pain, and our ICBPS patients are there in the pool and in the gym alongside patients with chronic back pain and disabling arthritis, and get the benefits that are evidence proven that the more exercise you do and the more you get up and do things, the better you are able to manage personally your chronic pain. But there's also exercises that will also ameliorate the chronic pain. These are low-impact exercises. We found that exercises in a warm pool without high impact have been very beneficial. We found that walking, swimming, and if the patients like to get very active, the elliptical is better than the treadmill and certainly better than the stationary bicycle. And we found that doing these have been very helpful. Lately, we've been working with physiotherapists and yoga teachers to teach the appropriate stretching exercises and mind exercises that go along with the stretching exercises, and that's been extremely helpful. We've also learned about maladaptive coping. This is not just in patients with interstitial cystitis or bladder pain syndrome. It's for all patients with chronic pain. But the IC patient, because the pain is in the bladder and vulvar, vaginal, and pelvic area, we see a lot of psychosexual maladaptive coping, which we have to deal with, and we found that it's different than back pain, as different than arthritis pain that we see in chronic pelvic pain. So we have to look at this differently. And I'm going to be talking about catastrophizing, pain contingent rest, and solicitous behavior from others. And we've learned a lot from this. And this psychosocial impact in ICBPS has allowed us to put this research into practice to help our patients. To start with, we had to find out what was going on. And we've developed a comprehensive medical and psychosocial impact questionnaire that we're using in our patients in our clinic now that helps us determine the clinical psychosocial picture for each patient. Of course, we have to quantitate the pain and urinary symptoms. We must look for associated medical conditions beyond the bladder. But then we have to figure out what patients actually value and the impact. And for different patients it's different, but for many it's the quality of life, mental and physical, the disability, sexual functioning, activities, and that's different for everybody. Suicidal ideation. This has become an extremely important focus of our group We've had one of our patients commit suicide. We know of many others. We've done a web-based analysis of over 1,000 patients, which we will be presenting to the American Urologic Association this year, and we're developing programs that's going to help patients deal with this suicidal ideation so it doesn't progress to actual implementation of suicide. We've looked at coping mechanism, catastrophizing. I'll talk to you about it in a minute. Depression is a major problem. Sleep disorders. It's very hard to have a good quality of life if the pain and urinary symptoms are depressing your sleep. And social interaction is a major impact on patients. And while we wish we could pick social partners for all our patients, we can't. So we have to work with what we have. So what have we reported? So we've looked at 2,000 of our urologic chronic pelvic pain patients. We've contributed to 27 peer-reviewed studies on psychosocial understanding of this condition. And what we've learned as far as coping is patients that learn to cope better with exercise, mind over matter, whatever, mindfulness, do a lot better. We've learned that catastrophizing is such a maladaptive coping mechanism. The 3 stages of catastrophizing, and patients go into these 3 stages, one being rumination, thinking too much about it from the time the patient wakes up to the time they go to sleep. If you're thinking about it all the time, it's very unlikely that you're going to get better. Magnification is the second catastrophizing, is making the pain appear to be worse than it is. So the pain is something that you were managing, but because you're thinking about it all the time, it gets magnified. Now, only about 25% of patients get into this second stage of catastrophizing. We see it about 30 to a third of the patient go through the rumination. And it's understandable. The worst is the helplessness. This is the patient with a suicidal ideation. This is the patient we cannot help with medical therapy. The helplessness is the stage of catastrophizing where I've seen all the doctors. They can't help me. No one can help me. I will not have a great life. And once you get to that point of helplessness, nobody can actually help you until you go through, I'm going to show you the program. Social support is extremely important, but we can't mandate that. We can't pick a patient's partner. But we can try and modulate how that partner helps. With females with ICBPS, solicitous behavior from others actually is some benefit. Well, a patient should not make everybody around them feel bad or sorry for them if they have a social support that helps support their disability. Make sure they know where the washrooms are. Make sure they're not doing high-impact exercise. For the male partner, it'd be nice for him to take out the garbage, do some vacuuming, maybe make the beds once in a while and wash the dishes and clothes, because that actually does, and we've shown that it helps patients with this condition. The other is pain contingent resting. Believe it or not, it's more of a problem with males with chronic prostatitis than it is with females. But male contingent resting is a maladaptive coping behavior in which patients with pain sit around and do nothing. It's the counterintuitive coping mechanism of exercise. So if you feel that if you sit around and do nothing and sit on the couch, you'll actually find that that is counterproductive. Your pain will get worse and management becomes difficult. We've recently learned the importance of illness perceptions, and this is a sort of a mind game, that patients who have illness-focused coping do much worse than those who have wellness-focused coping. And this is something we've learned to be able to actually teach patients, that they shouldn't be guarding and resting and asking for assistance. What they should be doing is exercise, stretching, seeking social support in a positive way, relaxing, and self-talk, which is what we teach. So how do we tie these in together? Well, to start with, we get the illness stimuli. Patients present with pain and symptoms. Then their illness perceptions in respect to cause, consequences, control, cure, identification, and timeline, how chronic it is influenced by coping behavior, the behavioral, the cognitive, the emotional that I talked about, and we end up with this psychological, physical disability that I mentioned. Now, The only thing is, this is our model that we published, and it turns out to be wrong. It's not that easy. With all our patients, we were able to make very sophisticated modeling of how one type of behavioral modification or maladaptive coping impacted on disability, quality of life, mental quality of life, physical, and the symptoms themselves. And we've ended up with this model, which we're just about to publish soon, is this final model showing only the significant pathways. There's many more pathways, but I've taken them out because you really won't see it that well. But what this shows is the impairments. It's not a linear model. So control perceptions and negative cognitive emotional perceptions are fighting against each other and will impact either positively or negatively on illness-focused coping, wellness-focused coping, or negative emotional regulation, which again impacts on physical disability and positive or negative mental health. Now, what we've also found is there is a bioloop, and the bioloop is that physical and mental health disability, particularly the physical disability, ends up with a strong predictor of increased impairments. In other words, this is a loop, and so the more pain you have, if you go through the wrong end of this loop and end up with more physical disability, you're going to end up with more frequency, urgency, and pain. So how are we going to do anything about that? Well, we've used this information to develop an evidence-based cognitive behavioral therapy program. Eventually, it's going to be web-based. Well, right now it's web-based, and we're testing it right now. We've beta tested it in about 50 patients. It seemed to be very, very valuable. We're right now doing a sponsored randomized waitlist controlled design trial in which patients sign up for it. Half the patients will get the therapy right away, the other half wait for a bit, and then we'll compare to see how well this cognitive behavioral therapy does and how much it improves this teaching the patients how to change their coping, their wellness-focused thinking, and see if we can actually reduce disability and perhaps even the impairments by cutting down on that negative bile loop. Tip 8. Sequential monotherapy is a recipe for failure. I've been preaching this for a decade, yet the American Urologic Association put out guidelines, which is a stepwise program of lesser to more aggressive therapies. If one therapy fails, you stop it, start the next one. Next tier fails, you stop, start the next one, next tier. And this has been shown not to work. Evidence-based clinical trials show it doesn't work. Evidence from real-life clinical practice studies shows it doesn't work. So if that doesn't work, you can't throw this out because it's based on the expert advice, based on the best evidence that we have from clinical trials. Well, the way I personally believe to do it is we have to develop personalized phenotype type specific treatment programs. In other words, every patient is like a snowflake. While they all look the same, they are all unique. And each patient, based on the associated conditions, their psychosocial well-being, and their clinical phenotype, based on viewpoint is what we do, is we use that to develop a specific treatment program for each patient with individual goals and outcomes. And doing that, we looked at patients who were referred to us from other urologists who failed every single treatment. We were able to improve the pain, the urinary voiding of over 50% of those patients. But even more startling is that 90% of the patients were happier, more content, that they had improved quality of life, decreased disability, and more activity. Because unfortunately, when we look at our outcomes in medicine, we measure urinary urgency, frequency, and pain, when we should be looking at these more important patient-related outcomes. So summarize, what I've learned in 15 years and in a lot of research is that we actually have to treat the patient, not the condition. That sounds pretty self-evident, but that's not what's happening out there right now in North America. And to treat the patient, we start with the 3 tiers of education, diet modification, exercise, and exercises. Yes, in a patient with bladder pain syndrome, with organ specificity, we must treat the bladder. And urologists aren't bad at this, and sometimes we overdo it. We can use medications, and we can talk about that if anybody has questions about specific medications or specific intravesical therapies, and surgery. Now, surgery to treat the bladder is very, very specific. The surgery that we use is a simple 5-minute operation to treat Hunner's lesions, which is extremely successful. I'm not a believer in repetitive bladder dilation. I'm not a believer in bladder surgery, such as augmentation. Removing the bladder is a last resort in an end-stage bladder. In so rare a patient, I've only seen 3 in my whole career in 35 years that have an indication for this. We have to treat the other identified pain generators. We have to identify whether the pain generator is also from the vagina or the vulva, the pelvic floor, the bowel, fibromyalgia, and then we have to address those with multimodal therapy. And we have to address each patient separately because every patient is going to be different. We have to treat the mind, and that's what I was talking about in our psychosocial research. And our best approach is cognitive behavioral therapy, but also yoga helps, mindfulness helps, and other approaches will do the same thing. I didn't go into this, but we have a lot of research that we're doing on patients with opioids. We should avoid opioids if all possible in these patients, and if we must use them, they should be used sparingly for flares. Opioids in this patient population results in about a 30% improvement in pain. Other treatments that we can use instead of opioids can result in 28 to 35% reduction in pain. So we can avoid opioids and get the same pain relief, but we do better. One of the reasons patients with chronic pain get better is they use their own endocannabinoid, endorphin, and endogenous opioids to treat their own pain. When a patient is on continuous opioids, all those things fall apart. There is no endogenous personal opioids to rely on. It also completely affects the endocannabinoid, so your own cannabinoid system, like you produce your own marijuana type of thing, or your other internal coping mechanisms fall apart, and it ends up in a downward spiral. So what I do, and I've been successful in, I would say over 95% of the patients who present to me with opioids, I am able to tailor them off opioids and only use them for flares and intermittently for what they're supposed to be used for. We must think multidisciplinary approach. So I have beside me the irritable bowel syndrome clinic. Down the hall is the urogynecological clinic. The pain clinic with anesthetists is further down the hall, and I make use of these multidisciplines to treat the patient. But I have to be the one to identify the pain generators and associated conditions to be able to use the multidisciplinary approach in a healthy way that works. And the final tip is I tell every physician who I teach how to take care of IC patients, and every patient that I see personally, is that in this condition in which cure may not be possible. Now, I should tell you that some of my patients are cured despite what I do. Mother Nature is a wonderful healer. We've got to set realistic goals, and my goals that we set with the patient is amelioration of symptoms as much as we can, increase in specific life activities that are relevant and important to that individual patient, and improvement in quality of life, particularly mental, but also physical quality of life. And ladies and gentlemen, that's what I have learned in the last 15 years dealing with patients with IC, BPS, and the research that we've done to back up those tips. I'd be happy to take questions, and Tanya, I guess you're going to figure out how we're going to do that.
Yes, I will read some questions aloud. I had a couple of questions that were sent to me in advance, so I'm just going to, if you want to go ahead, you can just leave your PowerPoint up, Curtis. That's
Okay.
fine. Yeah. So we had one question. How would you suggest an individual patient find a doctor who could make a correct diagnosis outside the bladder? So many are referred to urologists, but like you said, they don't often necessarily look outside the bladder.
Right. Well, number one, the educated patient is the best advocate. So a patient who understands that ICBPS can be associated with other conditions outside the bladder and who's actually experiencing those, pain in the vulva, irritable bowel syndromes with alternating diarrhea and constipation, bloating and abdominal pain, fibromyalgia where every muscle aches, migraine headaches. So if in fact you have those, you must, as the advocate, bring that to the attention of your physician, particularly if you have a bond with a urologist or a urogynecologist that's managing you for this condition. The other option, of course, is to go to a urologist or urogynecologist who is recommended by an IC organization, such as the IC Network or the IC Association. They have physicians that they'll help you find a physician or a urologist or urogynecologist who has expertise. And almost all urologists who have real expertise and interest in this understand the concept of treating the patient as a whole, not just as a painful bladder.
Wonderful. Someone else asking, what is the role of E-level in the treatment of IC? E-level?
Right.
E-level?
It's Elavil.
Elavil.
Amitriptyline. Amitriptyline is not a wonder drug. It's not a silver bullet, but is it ever helpful in patients with a neurogenically mediated pain? So we have done studies in IC patients, and we've noted a significant improvement in many symptoms in many patients with low doses. Amitriptyline is an old tricyclic antidepressant, but we use it in doses much less than we use for depression. I tend to like the dose of about 25 milligrams a night, but I will increase that to 50 because the evidence shows the higher dose, up to 50, gives you better amelioration of pain. So what amitriptyline does through multiple mechanisms is decrease neurogenically mediated pain, which can be in the bladder, can be in the bowel, can be fibromyalgia pain. It can also improve to some extent urinary urgency and frequency. It can improve sleep, and it can improve nocturia, getting up to void at night. So it'll either be a success or not, and we can predict that best by the phenotype of the patient. It'll work best in the patient that doesn't have Hunner's lesions. It'll work best in the patient who has neurogenic inflammation, like a bladder hypersensitivity. So when you do a cystoscopy, you see nothing, but you get pain with bladder filling. It'll work best in the patient with associated chronic conditions such as fibromyalgia or irritable bowel syndrome. And if it doesn't work, you have to try something else. So the other thing we would go next would be the gabapentinoids, which would be Lyrica and gabapentin, but those are much more toxic, have more side effects, and work in a smaller percentage of these same patient population. So I use amitriptyline, but I only continue to use it in patients where it makes a very real difference in terms of pain, in terms of urinary symptoms, in terms of improvement in sleep and activities. If it doesn't work, I don't persist. I take them off it very quickly.
All right, wonderful. Let's see. Someone asking, what do you think of the use of alkaseltzer for bladder pain relief?
So we know that acidification of the urine increases symptoms in many patients. And we can increase that by overloading with vitamin C, drinking too much orange or grapefruit juice, or sometimes spicy foods that lead to increased acidity in the urine. We know that alkalizing the urine does and can improve symptoms in many patients. This can be alkaseltzer, or even cheaper, we just use simple bicarbonate, sodium bicarbonate, in our clinics instead of alkaseltzer. And there are products out there such as Preleaf, which will help alkalize the urine. Again, this is a type of treatment in which a patient will know within a week whether or not it is giving any benefit. But it's certainly worth trying because it's innocuous, has very few side effects, and if it works, it's wonderful.
Great. Someone asking your thoughts on hydrodistension and wondering how often or if you recommend it.
Right. So I use hydrodistension extremely cautiously. I will use it when I see a Hunner's lesion in a patient under local anesthetic. I will go in and I'll biopsy that lesion just to make sure it's not a carcinoma in situ or a cancer. I will cauterize that lesion right down through what we call the lamina propria, but try not to cauterize too much muscularis propria for a condition I'll just tell you in a second. And then I'll do a hydrostatic bladder dilation because I think it probably helps. In fact, hydrostatic bladder dilation can help 40 to 60% of patients with bladder hypersensitivity type of bladder pain syndrome without Hunner's lesions. But the benefits do not last. They may last as long as several weeks. The odd patient, it lasts for 3 months. Once in a while, it lasts for longer than 6 months. But the patient has such good relief and felt so good for a week or a month or 3 months that they want it again. And what happens, and we and others have shown that, is the second time it's done, you can't stretch the bladder as much. And the relief is less of a duration, and when the symptoms return, they're worse. So the patient wants another one, and we have to do it sooner. And again, when we dilate, we can't dilate as much, and the relief doesn't last as long. And the symptoms become worse when it does finally relapse. And we end up with a bladder cripple. The 3 interstitial cystitis patients I had to remove the bladder, they all had multiple hydrostatic bladder dilations, some as many as 30 to 60 in their lifetime. And we could trace how the bladder was getting worse each time. And what's happening is each time you stretch the bladder, it does a temporary benefit. But what it does is it causes fibrosis or scarring in the bladder muscle. So the next time the bladder capacity is going to be less. The frequency and urgency is going to be more, and you're only able to dilate it less. So I use it as a, not as a treatment, but as a confirmation that the patient does have bladder pain syndrome. The patient gets better, but when they come back in 6 weeks or 3 months and wanting another one, I will decline because I know in the long run it's going to cause more harm than good. However, that being said, I have had patients where I've done a hydrostatic bladder dilation and they get significantly better. I follow them for 6 months, they're still better. So I said, go away, come back when your symptoms come back. And they return 2 years, 3 years, 4 years down the road, never having another treatment, but now their symptoms have returned. That particular patient may benefit from another hydrostatic bladder dilation, and I wouldn't hesitate to do that in that particular patient because of the long duration of benefit that they had. I hope that answers the question. And by the way, that's controversial because not every urologist or urogynecologist believes that. The hydrostatic bladder dilations are very profitable. They're economically feasible for us as surgeons because they're a quick way to have a surgical procedure that makes the patient feel better. But I look at the maximum of cause the least harm possible over time, so I do not do sequential and serial bladder hydrostatic dilations in my patients.
All right, wonderful. Thank you very much. Let's see. In your opening, you mentioned your IC clinic is open to all of Canada. Where is it, and how does a patient get referred?
So we opened our clinic about 13 years ago. And we opened it. I sent a note around to the urologists just in Ontario, not outside Ontario, but the word got out very quickly somehow. And within 2 weeks, we had over 500 patients. Now in Canada, you cannot make a living taking care of IC patients. I do it because I have an interest, a research interest, and I have some research funding in nurses. It took me over 3 years to see those 500 patients. Because I also had patients that I had to see in my local area that were primary IC patients, which I mandated to see within 6 to 8 months. So it took 3 years. 2 weeks in, we had to close our clinic to all outside of Ontario. Then we closed it to outside of Southern Ontario, and then last year I had to close it to outside our local health, LIN, which is our local health care area, because lack of funding. We lost the funding. I used to have 2 full-time nurses. Now I have a half-time interstitial cystitis nurse because very few resources are being put into the treatment for IC, and so now I'm back relegated to taking care of local patients, and even then the waiting list is over 6 months. So unfortunately all I can do is teach other urologists the technique that we use, but I'm not able to see patients outside our local health care area.
All right, very good. Someone asking if you are familiar with the work of Dr. Landers in California, who's doing stem cell treatment, and wondering if you've encountered patients who've had the procedure.
Yes, some of the most innovative stem research for urinary symptoms was actually done at the University of Toronto by Leslie Carr. She was one of the main investigators. There was also many patients in Quebec. And the stem cell research, we actually did about 5 patients here in Kingston as well. And this was for patients with incontinence and refractory incontinence. And it was not very much of a success. The initial patients did well, and the program has since been collapsed. I got, I'm not going to say a bad taste, but I had a bad impression of stem cell research for this condition. And interstitial cystitis, bladder pain syndrome is much more complicated than just plain urinary symptoms and incontinence. So I actually believe that we first have to figure out what causes this before we start throwing around stem cells in the hopes that we're going to do some good. That being said, I really only like to comment on treatments that I have researched or used myself, and I will not denigrate any other innovative treatment that other people are attempting. At this point in 2017, I would not be using stem cell therapy in any of my patients.
All right. Someone asking, for people who do have IC as well as other autoimmune diseases or chronic pain issues, what advice do you have for those people as to how to manage all the conditions at the same time?
Right. I'm going to take it that this question came from a patient rather than a physician.
Yes.
Because I teach physicians how to do this. For patients, it's a different matter. They have to find physicians who will help treat this. And like I said, the best approach is being your best health care advocate, and that's you and your partner. You must be, just by being at this lecture, you now understand that many physicians and urologists understand the concept that the pain and condition is more than just a bladder problem in up to 80%. And we will not successfully manage patients unless we identify those other conditions and treat them. Now, most urologists are uncomfortable with treating all these other conditions. I'm not. I treat IBS, fibromyalgia, and vulvodynia. I don't treat migraine headaches and some of the others. But I do treat these other conditions because I know it's all part and parcel of the same person that I'm treating. And treating one will treat the other, primarily because of neurologic crosstalk. So all these organs and muscles and bowel and bladder and vagina, they all talk to each other through the central nervous system. So by helping one, I help the other. So not all physicians are tied into this, so you may need a multidisciplinary approach. You may need to have the rheumatologist help you with your fibromyalgia, a gastroenterologist to help you with your irritable bowel syndrome, a urogynecologist to help you with your vulvodynia, and a urologist to help you with the bladder pain, urgency, and frequency. It is important that one physician, and in Canada that's run through your primary care physician, organize and collate all this multidisciplinary care. It can also be done by an interested specialist, a urologist or a urogynecologist, but they will not do it unless you actually push for that. You must sometimes educate your specialist that you believe that your irritable bowel syndrome, your fibromyalgia, your vulvodynia is related to your bladder pain syndrome, and that perhaps all these should be addressed, if not by that particular specialist, then perhaps by specialists that he works with.
Very good. Let's see. There are a couple questions about medications, mostly people being curious about alternate medications to opioids.
Yes. So what do I use to take patients off opioids? The first is the understanding that most patients who slowly decrease the opioids have no increase in pain. I do this over a 6-month cessation period, and patients are quite amazed that 6 months later they have the same amount of pain, sometimes it's still a lot, that they had when they came in to see me loaded up with opioids. But what they also note is that food tastes better, life looks better, social interactions are better, quality of life is better, they can exercise more, the fog is lifting. All this is much helpful. Plus, once they're cut down and decrease opioids, other medications work. So amitriptyline, Lyrica, COX inhibitors, intravesical therapies, physiotherapy, all those treatments do not work very well in a patient who have lost their endogenous opioid system by taking exogenous opioids. So that's basically what I've learned. In Canada, we can use, and many places in the States, medical marijuana or cannabis, and I've used that successfully in many patients to try and wean them off the opioids. And by weaning them off, we just go to, like more powerful to less powerful to no powerful opioids, and we try and supplement that with other treatments as we're taking them off the opioids, and that includes everything from diet modification to exercise to things like amitriptyline, physiotherapy if indicated, and cognitive behavioral therapy. Patients will want to have to improve their quality of life and decrease their disability if we're going to successfully get them off the opioids. And like I said, I do use cannabis and marijuana. Our studies have unfortunately shown that it doesn't really reduce the pain that much, but it does improve the coping mechanisms that we are trying to teach the patient.
All right. Let's see. We have a couple of questions about some alternative treatments. So someone asking about internal physio and another about acupuncture and whether you recommend those.
Sure. Well, the internal physiotherapy is the mainstay of physiotherapy. Sure, relaxation, massage, and physiotherapy can be a benefit for fibromyalgia symptoms and elsewhere, but for patients, and that's 30 to 40%, maybe even as high as 50% of patients have dysfunctional pelvic floor tone, myofascial pain in the pelvis, trigger points, can be treated by internal pelvic physiotherapy. The key is to have a physiotherapy who understands pelvic pain, physiotherapist who has been trained in physiotherapy for pelvic pain, who can identify and treat those. We have shown in randomized trials that it does work. So it's evidence-based, it works. Now what about acupuncture? Well, acupuncture is one of those things I wish I had more experience. I've published about 3 studies on acupuncture, 2 of them positive, 1 of them negative. And it's so dependent on the actual acupuncturist. I actually went to China and sent one of my acupuncture physicians to China to the Beijing acupuncture clinic to learn how to do acupuncture for pelvic pain. He was never as good as the old Chinese acupuncturist that I used to use, who subsequently has retired, who's about 85 years old, who learned how to do it So I don't know how well it translates, so I'm going to tell you that I believe in acupuncture. I've seen it work in China. In fact, I've seen patients being operated on with nothing more than acupuncture anesthesia. It was amazing to see that in China. But it's very, very not user dependent, it's very technician dependent. So some acupuncturists know what they're doing for pelvic pain, and others are just following diagrams or what they were taught in their acupuncture school. Acupuncture has to be taken along with the whole idea of mind over matter. It only works in acupuncture believers. You know, I've never sent a patient for acupuncture who told me, I don't think it's going to work, I don't believe in it. It won't work. If I send a patient who says, you know, I think that's probably a good idea, I think maybe it'll work in me, it has a higher incidence and prevalence of success in those particular patients. So that's my take on internal pelvic floor physiotherapy and acupuncture.
Wonderful. Let's see, someone asking about the ICEA elimination diet and wondering if your clinic strategy is available for others, and if so, where and how?
Yes, so the ICEA elimination diet that we use is the one that's been tried and tested by hundreds, if not thousands of patients, and it's the one that's propagated by or promoted by the ICEA, the Interstitial Cystitis Association. It's the particular one that we use, and it's based on patients, talking to patients and surveys, and basically what it does is it gives us the most common combustibles. That's the type of food that are most commonly going to cause flares, symptoms, pain, urinary symptoms. But it's so interesting that every patient is individual, and these type of foods affect every patient differently. So if you can, you go on this very bland elimination diet, that information is available from the Interstitial Cystitis Association, which is one of the very good support networks. The ICN is another, and there's an international interstitial cystitis support network as well. All these are very, very helpful.
Wonderful. And I will find links for that elimination diet and include it in the resources for this webinar as well, because I think that is probably valuable for people. Let's see. I think we probably have time for one more question. There was a woman asking about your experience with IC and patients who are pregnant or postpartum and breastfeeding, and how you deal with flares and managing symptoms.
So the treatment of pregnancy by surgeons is always done with velvet gloves. Under no condition do we want to cause any harm to the fetus or any harm to the mother. And my feeling is less is best when patients are pregnant. Now, what's interesting is many patients, not all, but many patients do get better. Their pelvic pain improves while they're pregnant, only to return after the delivery. So I tell patients that I'm going to take them off any medications that I feel could affect the fetus, and because we don't know which ones could or may not, that's most medications. And we go with all the conservative measures that I talked about in the hopes that the pregnancy will actually result in improvement in the symptoms. Now, after the pregnancy, if the patient's symptoms return, but they had a fantastic benefit or amelioration with pregnancy, there is a case to put patients on hormonal therapy, that being birth control or otherwise, and I do that under the supervision of our urogynecologist. I will not prescribe medications if I can avoid it in a patient who is breastfeeding, just because we don't know the consequences of some of the medications we're using. So I'll tend to use more local therapies. That's intravesical therapies into the bladder, which I know are not absorbed. And those therapies are glycosaminoglycans, and that'll be Elmiron into the bladder rather than orally. I will use chondroitin sulfate, hyaluronic acid. May not be available in the U.S., but available in Canada. I will use intravaesical lidocaine, and I usually add alkali bicarb along with the lidocaine to try and cause desensitization. And by doing that, I know that I will not be causing any distress to the new baby if the mother is breastfeeding.